Okay, George, will you please sing the national anthem?
Good morning, everyone. It's just about 10 o'clock Eastern here, and I want to welcome you to the opening keynote of our virtual Friends for Life Indianapolis conference. Before we get started, I just want to let you know about a couple things. Included in the attachments to this webinar are two PDFs. One is the slide deck from George and Stewart, so that you can review it after the session. And the second are the instructions on how to use GoToWebinar from the user perspective. So if you have any questions and aren't quite sure, you can download that and it'll show you how the control panel works from your perspective. Also a reminder, we are recording this and it will be available on Tuesday to share with friends if you missed this. This particular webinar is going to have polling during it, and when I start the poll as the controller, that will take over your screen. We'll wait about a minute, let everyone answer, and then George and Stewart will address the poll questions. At the end of the session, there'll also be a little pop-up survey. We would very much appreciate your feedback. Just 3 questions on this particular webinar. During the webinar, if you have questions, you have an opportunity to submit them. And since this webinar is going to cover a variety of topics, George and Stewart have asked that if you have questions, submit them when you think of them, and we will direct them to get those answered during the context. With that said, what I want to do is thank all of you in the community for sticking with us through this very interesting time. And I really want to thank our sponsors, Lilly Diabetes, Dexcom, Insulet, Tandem Diabetes Care, and the American Diabetes Association, who have been very generous in sticking with us and supporting us in this effort to bring Friends for Life Indianapolis to you virtually. And with that, I'm going to hand everything over to George Huntley.
Hey, good morning, everybody. And I'm going to try to share my screen. If that almost worked. It's not in slide deck mode. There we go. How about that?
Very good.
Well, good morning. Thank you again for being here. Thanks, Jeff, for the wonderful introductions. And it is my great pleasure to be with you this morning, and I know we all have precious little we can do outside or outside of the house, so glad you're joining us this morning. I am George Huntley, and I am with my good friend Stewart Perry, although I'm not really with my good friend Stewart Perry. I'll introduce myself, and I'll let Stewart introduce himself. I've been T1D green bracelet for those in the Friends for Life community. Although I don't have my bracelet on, I wish I did. Since 1983, family members with it, been in the volunteer world and the advocacy arena for a long, long time. I'm a former national chair of the board of the American Diabetes Association, and I'm currently the president of the National Diabetes Volunteer Leadership Council with my good friend Stewart Perry, and also and a board member of Children with Diabetes. Stewart, tell us about yourself.
I think you're treasurer, George, so you handle the money, correct?
That's true, and that's dangerous, but that's true.
That's exactly right. I'm Stewart Perry, and I'm all the things George isn't. And I have type 2 diabetes. My father is insulin dependent type 2. My mother has type 2. My uncle was insulin dependent type 2. My great grandmother was insulin dependent type 2. I have a son with type 1. And like George, I have been on the advocacy platform of diabetes for over 30 years. I'm a former national chair of the board of the ADA. I serve on Children with Diabetes. I serve as vice president of the National Diabetes Volunteer Leadership Council, and I'm vice chairman of DPAC. So I spend a lot of time trying to either fight bad things with diabetes that affects you and your family, or prop up good things with diabetes that affects you and your family. So George, let me turn it back to you.
Well, thanks, Stewart. And that he does exactly that. He fights for the good and defends from the bad, and that's what we're here to talk about. So the topic this morning is affordable access to insulin and other things that keep you up at night. And we'll get into a lot of interesting dialogue. As Jeff mentioned, we're hoping this to be interactive. So if you have a question, please do use that chat button down there and type in that question so we can get it. And there will be interactive polling throughout the presentation. So please give us your feedback, because that's important. You know, as we're
first things first, George. George, first things first, buddy. Okay.
Oh, yeah.
Sanitize your hands. Okay. No telling who you might reach out and touch.
That's true. At no time do my fingers leave my hands in this whole presentation. You know, as we're in this video world and we're out getting this, and we're going to be indoors for an extended period of time, the whole notion of video conferencing is really getting kind of interesting. And I think as it evolves, we're going to see something kind of like this happen. You know, you just don't know. You know, right now I don't have enough hair that you'll be able to tell, but I think later on we're gonna be wanting to filter those lenses and things like that. Or I just want to start it off a little bit amusing. All right, the subtitle of this presentation is "Blessed are the fuss makers," because when you're an advocate, you're going to be a fuss maker. So this is things that keep you up at night, and also what you can do about it. So with that, we're going to kick into it. And Stewart, would you kick us off?
Sure. In today's talk, I feel like I'm on a TED talk. In today's talk, we're going to talk about who are the fuss makers, define advocacy, what to make a fuss about, the hot topics, how to make a fuss. And as George is so ripe and ready to say at any moment, are you ready to make a fuss? So go ahead.
I hope the answer to that is yes.
There we go. By the way, George and I have not done this videotape before. We haven't even practiced it. So you all will bear with us if we misspeak ourselves. So let's talk about who are the fuss makers. Let's talk about advocacy first. George?
Sure. Well, who are the fuss makers? Spoiler alert, it should be all of us. It should be everybody on this call and everybody in the diabetes community. So let's talk about the definition of an advocate. You know, a person who publicly supports or recommends a particular cause or policy, one who pleads the cause of another, one who defends or maintains a cause or proposal, one who supports or promotes the interests of a cause or a group, someone who's stepping out of their comfort zone a little bit, someone who makes a fuss. So are you a fuss maker? Hopefully 60 minutes from now, you will definitely be.
Actually, it's 53 minutes, George, sorry.
53, well, we'll go quick. We're now going to talk about what to make a fuss about. What are the hot topics in diabetes advocacy? Because there's a lot of things to make a fuss about. Stewart, would you walk us through that?
Sure, George. Rising insulin costs. I know nobody here is on this. I want to keep calling it a call because I'm old. Nobody on this webinar would be excited about rising insulin costs. School issues. If you have school children or you have grandchildren or you have neighbors that have school children, the way that kids with diabetes are treated in schools has got to be a major thing for you to think about. Insurance restrictions. Now, in full disclosure, I have been licensed to sell health insurance for over 30 years. George is actually the plan administrator of his company. George is the CEO and CFO of a rather large multinational national company, and he does this for his company. Insurance restrictions, non-medical switching, pump choice, fail first technology, step therapy, copay accumulators. I know every one of you know exactly what all that means. Preserving diabetes coverage gains. This is basically the Affordable Care Act and the things that we got as a result of that. Diabetes research funding, and then Medicare and Medicaid issues. Why do we care about that? Because most of the companies that sell health insurance or give all of us our health insurance tend to follow whatever Medicare does. So As Jeff said, we're going to have a chat. We have a chat feature on here, and we have a polling feature to ask questions. So if you've got one, I'll let George answer all of them, but if you've got one, please click in whenever you want. Okay, so what's all the fuss about? What are we talking about with insulin costs? Okay, what's the problem, how we got here, and what in the world can we do about it? George?
I don't know.
Okay, end of the call. Ladies and gentlemen, thank you for being here with us today.
Sorry, guys. All right, so what's the problem? Well, high costs can lead to very dangerous rationing. People are not taking their insulin because they cannot afford it. And I do believe there's a poll question, Jeff, if you could launch that for us, for folks to say if they have.
Poll is launched.
Poll is launched. Have you or a loved one ever taken less insulin than prescribed or eaten fewer carbs than planned due to the cost of insulin? These are really hard questions for you to answer. There's going to be yes or no's kind of things, but we appreciate your input in this, because when we're advocating for people on behalf of people with diabetes for this access to insulin and making a big deal about it, it's important to be able to say how many people are rationing their insulin and how many people are impacted by this phenomenon that we're dealing with high costs. This is a study that said 1 in 4 patients surveyed at a leading diabetes clinic reported cost-related underuse of insulin. Bad things happen when that occurs. So we appreciate your time in clicking through here, and so we can all understand this. I think we understand that this happens.
All right, it's been a minute. I'm going to close the poll.
Very good.
And here are the results.
That's interesting. All right, well, this is why we do
so
this.
Here are the results.
28%.
Go ahead, George.
Yeah, it's okay. No, thank you. I can see it now. The interesting thing is it blew up my my presentation. So 28%, more than 1 in 4, have rationed their insulin. That should disturb all of us. It certainly disturbs me. Okay, if we can get the slide, good gracious.
There we go.
Yeah, all right, so now we're back to the full slide deck, so that will be fun. We'll deal with that. But I think it's worth the technical glitch to get everybody's thoughts and insight. So we're about 1 in 4. Yeah, interesting. Okay, why ration insulin when it's covered? So as Stewart mentioned, in my day job, I've been the plan administrator of a self-insured health plan for over 20 years. So I know the employer side of the decision-making process of health plan design. And one things that we do at NDVLC is we actually are partnered with JDRF, and we go out and educate employers on their plan design so that they protect their participants from list price of insulin. So, why would you ration? Well, you can't afford it, obviously, high cost exposure. But you also can ration because there's a delay in getting the insulin. You think you may be able to afford it, but the plan changed and you can't get the brand you want, or you've got to wait for a prior authorization or a refill for the approval, and then life happens. You could just drop the thing, and sometimes those vials break. Sometimes it gets hot in the car. Sometimes it freezes if you're in the cold states. And hey, by the way, a 90-day supply for just under $3,000 is anything but a bargain. So that's why people would ration. You guys know this instinctively, but there are more than one reason why you could find yourself in that situation. So I'm going to talk a little bit about how we got here, and what's happened in the health insurance world that caused us to have this phenomenon. So first off, there's an increase in high deductible health plans. All right, so that's happened over the past really decade now. Almost half of people that are commercially insured are in a high deductible health plan. So that's almost half of the people with commercial insurance. And that now includes pharmacy in the deductible. You go back 10 years prior to the high deductible health plans, pharmacy didn't used to be part of the deductible. You would typically have a major medical deductible, but pharmacy wasn't part of that plan. So now you've got pharmacy part of the deductible, and it's a high deductible health plan. So again, 10, 15 years ago, the deductibles were $250 or $500. Now they're $2,500 or $5,000. So when that happens, and now you've got your drugs in there too, you can create a big problem. Now you've got increased use of co-insurance versus co-pay. It used to be that we would pay $30, $25 for your drugs at the pharmacy, and that was it. Now you're paying 30%, and you're paying 30% of a large number because you're not getting the benefit of the price negotiation that's happened within your plan. Again, if the employer doesn't design the plan correctly. Drug prices have gone up as a side, parallel impact of all of this. Drug prices have gone up. So the high deductible health plans happened. And while it was all happening, the drug prices went up because the pharmacy benefit managers have come into play. And we've got higher rebates, discounts, etc. And this next slide is a little bit confusing. So I'm just gonna make my friend Stewart describe it.
Now, George, before you go to that, what happens when you play the Beatles' White Album backwards?
I think it
says PBMs are the devil, okay? So pharmacy benefit managers are absolutely, in my opinion, one man's opinion, one of the major cost drivers in both insulin and other drugs. So, all right, go on to the next screen.
Hey, Stewart, I sent you a question from one of our listeners, and either you and George can answer it. But Stewart, do you see it to be able to read it?
No.
So it says, speaking of blowing up, COVID-19 is going to blow up those of us who have health insurance to afford, able to afford their coverage via COBRA. The result will be more people with loss of coverage and paying list price for devices and drugs. Any comment on that for either of you?
Well, yeah, and I think this is a very, very good consideration for the pandemic that we're dealing with right now. People are losing their jobs. And some companies are great enough to continue those people on. The company I'm CEO of and the company George is CEO of, I don't think we've laid anybody off yet, George, have we? So some people are not at the office or not working, but they're still got their benefits and they still have their salaries. Not every business can afford that. So people are going to be looking at COBRA. COBRA, for those of you that may not know, is the part of the law, federal law, that requires an employer who gives you health insurance or lets you buy health insurance, either way it happens, you have to, after someone is terminated, you have to, for a certain period of time, continue their health coverage, but not at the same price. So that price jumps extremely high. George, you probably had more experience with this than anybody. And so this is going to cause people, depending on how long this national emergency continues, it's going to cause more people to go to COBRA. COBRA doesn't have as good coverage. COBRA does have it. It's a real situation.
COBRA winds up being extraordinarily expensive. I mean, you could be paying thousands of dollars for a family coverage on a monthly basis. You can be paying nearly $1,000 plus, maybe $1,500, depending upon the plan that you have in place, just to keep the coverage. So if you find yourself in COBRA, and I'm just going to go off on a small tangent because it's an important conversation, because there could be a lot of people, or hopefully not, but there could be some folks on this call that are impacted by that. When you go to COBRA, there is a 60-day window that you can look backward. So you do not have to elect COBRA the day you are suddenly terminated and find yourself without insurance. You can actually go for 60 days, find that you have a claim, and then go back retroactively and elect COBRA at that moment in time. So I would encourage you to make sure you understand how COBRA works, because it is really, really expensive, and it may be cheaper to just go continue to get your drugs and your diabetes supplies on your own until you find yourself with another option, versus paying for COBRA and then still having to pay for all your diabetes supplies and all those drugs because you're still in a deductible. So beware of that process, but COBRA is there if you have really, in my mind, catastrophic healthcare claims. And I hope nobody on this call has it, but understand that you have a 60-day window to look backward and make that election should it need to happen.
Okay, so the other question, George, was what is the Indy VLC?
Indy VLC is a 501c3. Stewart and I are part of this 501c3. It is formed by several of our former national chairs of the board of the ADA, but now we've expanded that board to include other diabetes community leaders it's dedicated to advocacy on behalf of people with diabetes. So we have been doing this for a very, very long time, and it allows us a platform to go out and speak on behalf of people with diabetes, advocate on behalf of people with diabetes, and it's been a very interesting experience being part of that and founding that about 6 or 7 years ago. And I would urge you, if you really want to learn more, to go to ndvlc.org.
Yeah. Okay, so let's go back to this slide if we can, George. So if everyone watching would take their left hand and put it over the left part of the slide as you see it on your screen. Anybody here that's heard that drug prices are cheaper in other countries than they are in the United States? This is the reason. In other countries, what you see is the right-hand side of the screen. So George, I think you've got a laser pointer or something you can use.
I was trying to find that earlier and I failed, but
okay, all right.
My mouse at the very least.
So on the right-hand side, you've got the consumer. This is where that's us. The consumer's the patient, and at the bottom you have a drug company. So the drug company makes the vial of insulin, sends it to the pharmacy. The pharmacy delivers it to the consumer. The consumer pays the pharmacy the price, and then the pharmacy sends money to the drug company. Over here on the right is the wholesalers. They are becoming, with pharmacies buying out other pharmacies and the major pharmacies becoming almost monopolies, the drug wholesalers are not quite as big of a deal as they used to be when we went to our neighborhood pharmacy owned by the man or woman that lived 2 doors down from you. But they're still there for some of them. So that is the way we think about how a vial of insulin gets to us. But then you got to follow the money. As George loves to say, follow the money. So on the left-hand side, you've got the dollars we pay to the health insurance company. And then the health insurance company pays a fee to the pharmacy benefit manager. The pharmacy benefit manager then sends a fee to the pharmacy. And then there's another line. George, you want to explain that green line there?
Well, it should be the biggest line on there, because this green line, so that the consumer pays $300, comes down here to the drug company who gets about $300 to use round math. We'll get into specific math in a little bit because it's more than that. And it goes over to the pharmacy benefit manager. Of the $300, 2/3, 70+% of it goes to the pharmacy benefit manager. So now the pharmacy benefit manager, and let's think Express Scripts, let's think CVS Caremark, let's think Optum Health. Those three have what, 80+% of the U.S. market of drug transactions in the U.S. market. So
87%.
It's a big number. So they pretty much own the U.S. market. They're getting 70% of the insulin transaction, and they're keeping an undisclosed portion of that 70%, and they're sending the rest up to the insurance company or the employer health plan, right? In a self-insured plan like my company's plan, the employer gets that money. So you've gone to CVS or Walgreens, you've paid $300 for your insulin, and your employer just made, I don't know, $200, $150, $200 a profit because you went to the drugstore.
Are you sure, George?
Yeah, I'm sure.
I mean, no, you're sure that's what they made. So you can go and look at this process online, or you can see that's what it was, right?
There's not exactly transparency in this notion.
Okay. All right. Well, then, George, why don't all the drug companies just get together, the three insulin companies get together and say, we're not paying rebates anymore?
Because all three of them would have to do it together, and that would be illegal. That would be
illegal. Illegal by the federal government?
That's correct.
Okay. So I'm from the government. I'm here to help, right? Okay. So I'm still a little confused. So if that money is sent to my insurance company, what do they do with it? Or my employer?
They use that money to keep your plan costs down. Your premiums are down because of all that money.
Well, unfortunately, we can't ask everybody online to show us a show of hand whose premiums have gone down lately. But okay, so
yeah, it's a situation where the sick have just subsidized the healthy.
So that means someone with diabetes that tends to take more drugs than other people with other chronic diseases is subsidizing health insurance premiums for other people, correct?
That's exactly right.
But that's contrary to the way insurance works. Insurance is supposed to work that many pay the losses of the few. Hasn't this made us upside down?
Completely.
Obviously, I don't have the education to understand this system. But now, you know, we had a question, George, and let's try to address it right now this way. Pharmacy benefit managers, when they initially started, they started because they were going to group all of the different pharmacy bills that came in for a company that has millions of employees, say a Caterpillar or Microsoft or whatever, and group them all together and bundle the billing and make sure it's all right. Correct? Isn't that the way they started?
That was the idea. Yeah.
Okay. And then they came up by stealing it from Medicaid, actually. They came up with the idea of formularies. And so then they went to the insurance companies and said, hey, let us run your formularies and we'll get your drug costs down. But by doing that, then they hold the drug companies hostage and say, if you don't give us a rebate, you don't get on our list. Is that the way it works?
That's exactly right. So this money is a market access fee to these formularies, the 87% formularies, and it's a game of chicken. If you don't give me the rebate, if you don't give me that market access fee, then I'm not going to give you access to my plan, my formulary. They are taking one form of fast-acting insulin, one form of long-acting insulin, one form of a blood pressure medicine versus another blood pressure medicine. It's not just insulin here. This is just how the system now works. And these dollars are bigger and bigger and bigger because these guys have figured out how to make money.
Well, but so have the drug companies. I mean, they just raise their premium or raise their price of drugs to cover the rebate, correct?
And that's absolutely right. So the drug company can afford to pay whatever it is they want to pay because they just raised the list price. And let's go to the next.
It falls on us.
Yeah. So this next slide, if it'll move, no time do my fingers leave my hands. There we go.
Okay,
this illustrates that, Stewart.
Yes. So this slide here shows, and the bona fides of this slide, I'm an old Southern boy, the bona fides of this slide are down at the bottom. So this slide here shows the actual net price that insulin companies receive for dispensing their drug, right? And the top one shows what the list price that we pay is going to, correct? Is that the way I see this slide?
That's correct.
So there's like $232 difference. Somebody's got my $232, George. Who is it?
It's that PBM guy.
But it's not just them, it's the insurance companies too.
Right, because they wind up keeping most of that money.
Okay, so I mean, to be fair, the PBM doesn't keep that entire money. The insurance companies keep it.
That's
okay,
correct.
So if I were trying to change this system, I would be modifying not just PBMs but insurance companies.
Right. The PBM has set up the structure that causes that whole rebate to happen, and the insurance companies are, quote, reaping the reward. That being said, if the insurance company just paid the $68 to begin with, they'd be in the same situation that they were before. So it's this inflated game that's been created by the desire for the PBM to keep a slice of that transaction. That's really what's caused this whole thing to balloon out of control. And before there was a high deductible health plan, nobody cared. Nobody noticed this happening in the background. But now patients are paying for it, and it's front and center.
So George, can you, because once again, we don't get to see in everybody's living room while they're watching this, and ask, does everybody truly understand what a formulary is? Could you explain exactly what we mean when we talk about formularies?
Yeah, so the pharmacy benefit manager on behalf of a plan selects a drug in every class so that and has negotiated the lowest price, net price for that plan to pay for that class of drug. And there's typically one drug per class, sometimes two, but typically one. And the negotiation is about getting access to that formulary so that you get on that, so that the drug company can sell their drug to that formulary, et cetera. And the employer gets the benefit of all of this, or the insurance company. But the problem is it's not getting passed on in many cases to the patient. And certainly if you're uninsured, it's not getting passed on to the patient, because what's happened here is list prices have been artificially inflated because of this whole phenomena of a market access fee. So even if you're not in the market because you're uninsured, you're still paying list price, because the games that have been played have caused the list price to inflate.
Okay. So if we had all drugs, all classes of all drugs on a formulary, they couldn't charge a rebate.
It would be a lot harder, and again, then there would be the drug company would have a reason to say no, thank you, because we're already on all the formularies.
Okay.
There's a right answer in here, but we haven't found it yet.
Okay. And once again, we're the only country in the world that has this convoluted system. Nobody else has it, correct?
Correct, and thank goodness, because as bad as this is, and misery loves company, I wouldn't wish this on the rest of the world. I'm glad the rest of the world doesn't have to deal with this mess. I just wish we didn't.
We have pontificated enough on this, George. Let's go on to the next slide.
So we've learned through this experience, how important graphs and math can be. So hopefully the math you just saw is impactful, and hopefully, we're all doing what we need to do to bend that curve downward. But I thought, as a math guy, I thought I'd share this important illustration for everyone. So now let's talk about math, since I'm on math. It is so confusing as to what you can pay for insulin. So this is an example I did last weekend, Saturday of last weekend. I just went out and said, if I were to buy 5 pens of Lantus, what would I pay? Well, if you're paying list price last Saturday, you'd pay $442 for 5 pens of Lantus. If you wanted to go to GoodRx and pay a cash price, you'd pay $357. So no one should pay list, and why would list be out there? If you have a plan, you're insured through your health plan, but you've got 30% co-insurance, that 30% co-insurance is on your list price. So you're going to pay $133. That's a lot. Or you can go to a manufacturer assistance program and pay $99. We'll talk a little bit more about that, but almost all three of them have an assistance programs, and $99 is about you can buy your insulin on a monthly basis for $99. It's typically outside of your plan, so you're not getting credit for your deductible in many cases when you use that, but it's a lot better than paying $357. It's a lot better than paying $442. Or hey, maybe you're paying your copay, maybe your standard copay is $50. You've passed your deductible, you've got a decent insurance plan. In today's world, $50 is a pretty good price at this point. The word is getting out. So even the PBMs, as evil as they may be, are starting to understand that they've got to offer plans that protect people with diabetes. And so Express Scripts in January of this year came out with a plan for $25. All insulins are $25. The issue there is it's not in every plan they offer. So we have NDVLC, one of the things we do in partnership again with JDRF, we're going out and trying to drum up business for these $25 plans. The employers have to want to use that and want to offer that. And it's certainly in their best interest because people with diabetes are far cheaper if we take our drugs and manage our disease than if we don't. CVS Caremark came out with an RX0 plan. They're giving it away in their plans. So these a year ago, these weren't on the slide. So we're making progress in all of this. And bear in mind that the insurance plan or the employer is paying, I'm going to say about $85. That's a rough guess. In the $68 in the other slide, there's fees that they're going to pay legitimately to the PBM. So let's say they're paying $85. Even at 30% coinsurance, you're paying more than the company pays. The company's still making a profit on your purchase of insulin, even at 30% coinsurance. It's crazy.
So George, we had a good question, and since you're the math guy, I'm gonna let you answer it. If you have no insurance and you go pay $442, who keeps the rebate?
The PBM.
That's what I thought, because that's in their contract with the pharmacy.
Yeah.
There's things called spread pricing. There's lots of other things that we don't have time to go into today. But the PBMs, they have got the best attorneys in the world. Okay, these contracts they write with pharmacies are unbelievable. And if you don't believe it, go talk to a pharmacist. They'll tell you all about it.
Good point. I'm gonna move us on. Stewart, talk to us.
Okay, so we believe both CWD and all the organizations George and Jeff Hitchcock and I are involved in, we believe that nobody should ever ration their insulin. Nobody should ever have to ration their insulin. And for God's sake, nobody should ever die because they can't get insulin. So it's okay to ask for help if you're struggling or you need something. We just recently, George, I got to give George props. Indiana was the only state in the United States that did not allow for over-the-counter insulin without a prescription. And because George said, I don't think so. And George, along with a lot of other people's help, have gotten that changed. Correct, George?
Yeah, we're talking about that in a second. Yeah.
Okay. So understand and maximize your coverage. Okay. Know what your insurance coverage is. Ask for cash prices. Until July of 2020, the pharmacy cannot tell you that you can get something cheaper if you pay cash instead of using your insurance. After that, they can if they will. Use retail discount programs. That's what George just talked about when he's talking about GoodRx and those other things. Enroll in discount and patient assistant programs. We'll talk about that again in a minute. Check prices at member warehouses, Costco, Sam's Club. Many times you can find stuff cheaper because they're trying to get you in the door to sell you other things, so they take a little bit of a loss on drugs. A community health center or other low-cost provider, if you don't have insurance and you can't afford your insurance, that's where you go. Talk to your employer about insulin costs. George goes around the country and on these kinds of calls talking to major employers about how they should structure their health plans with insulin. And George so far is making great inroads through NDVLC's program. Talk to your diabetes care team about lower costs. Now, not all endocrinologists and not all primary care physicians understand it. And my endocrinologist, I sent them a bunch of information that they said, oh my God, this is wonderful. Thank you. We hadn't seen that. So if you know this stuff, if you're one of the people that is an advocate and you're on this call, take information to your doctors and make sure they know. Because when most people have a problem affording their insulin, the first place they call is their doctor. So let's talk about the uninsured and the underinsured. All three insulin companies have now come out with insulin plans. George, talk about your experience with one of them. You don't have to name them if you don't want to, but talk about your experience.
We were on an NDVLC, we were on a call and talking about one of these plans and one of these programs. And while I was on the call, I was multitasking. I'm sure none of you on the call on this are multitasking right now, but imagine, if you will, I was actually multitasking on a conference call, and I logged on to the system, signed up, and received my coupon, if you will, that got me the copay card of the $99 supply within minutes while I was on the call. These things don't take a lot of time to do. It seems like it might be hard, but it is not hard. If I can do it, anybody can. And I would encourage you, for those, if you have a friend that needs $99 a month supply, if that's going to help somebody that you know or love, please send them this information. Please encourage them to log on to any one of these, whatever insulin they're using. All three of them have really good plans right now, and they've made them more user friendly than they were 2 years ago. They're actually pretty easy to get into.
So George, we've been talking about insulin. We've been focusing on insulin, correct? But what about pumps, supplies, other drugs?
All of these things are, and we're gonna talk a little bit about that in a minute as we get into. So I'm gonna pause that question and get into what's going on right now in staying on insulin, on the federal cost of insulin issues. This is a very unique time. There's some good things and bad things that have gone on. On the bad side, the point of sale rebate pass through almost happened last year. It was a policy that HHS put out, and they were going to move forward with it. And the Congressional Budget Office, that's what CBO, it's a bunch of accountants, and I'm an accountant, and they're giving me a bad name. They defeated the notion of point of sale rebate pass through because it was going to be too expensive for Medicare to give up all those rebates. Now, part of that math was they did not assume that Medicare was going to then negotiate the price down to what the net should have been. Medicare nobody should make a profit off of your purchase of a drug other than the drug company. And there should be a fee, but this is crazy. But that got defeated last year. Chronic disease management was exempted from deductibles and high deductible health care plans last summer. That was a major win for people with diabetes, and that happened last summer. What that did was removed the gray area in whether a plan that's a high deductible health plan could legitimately or legally exempt insulin from the deductible, or exempt your other supplies or your pump supplies and things like that from the deductible, because it wasn't clear that you could. As we were talking to employers, many employers were already doing it and were sticking their necks out. And we talked to also several others who said, our attorneys tell us we're not allowed to exempt insulin from the deductible because it's not on the prevented drug list within a high deductible health plan. The good news is the government clarified that last summer, and now that's no longer a barrier, but it says those critical words, it says may, it does not say must. So a high deductible health plan may exempt chronic disease management from the deductible, but they don't have to do it. So again, we're out there advocating to drive demand, to make sure employers understand that that's important. There's a lot of other bills that were good and bad under consideration. Nothing moved. Nothing's going to move right now. I know that shocks everybody. But I will say this, guys. Next year, 2021, regardless of who wins this election, and we can have another discussion on that offline, health reform debate will restart in this country next year. And so if you're not a fuss maker today, be a fuss maker by next year. We've got to raise our voice, make sure the voices of people with diabetes are being heard, because things are about to start getting interesting, and we're going to have a window of opportunity that's probably only going to last a year. So stay tuned and be prepared. I'm going to talk about state level issues. Very interesting. A lot of these, a lot of the states have picked up because the Fed isn't moving, so they want to protect their constituents, the people living in their states. But the federal government's not doing it, so the state, there's been a lot of activity. In the state of Indiana, as Stewart mentioned, and thank you, and Jeff, I think there's a poll out there that I'd love to have, if you could launch, on over-the-counter insulin, because we encountered an interesting thing. Were you aware of the old human insulins as an over-the-counter option?
Poll is up.
Poll is up. Were you aware of that as an option?
George, while we're waiting on the answers, continue to go on this slide.
Yeah, I sure will. So these drugs were around prior to 1996. So by the time if you listen long enough, you'll know the answer is yes, because you'll know it. These drugs were the human insulins that were on the market before 1996, when the new analogs, the quote new analogs, started to come out. I was on these drugs from 1983 to 1996. They kept me alive for a very long time. I will say they are not as good as the analog insulins. The very simple way, and that blew us out again, the very simple way of thinking about them is that, there we go.
All right, George, here's your results.
All right. Survey says
65% yes, 35% no.
Okay. So a third of you didn't know. It was interesting. So two quick things on this story. I have to keep restarting the side. Okay, so here we go. So two quick things on this story. One is that these drugs, for those that don't know or don't remember them, were a scenario where you had to eat to counter what you've injected. In the new drugs, you can dose your insulin based upon what you eat. So your quality of life is significantly improved on the new, more modern insulins. But the older insulins did keep you alive, and you could work your way through it, but it was not as easy to manage at all. But they're a lot less expensive. So the over-the-counter insulins, the old R, the N's, they're about $25 a vial at Walmart, unless you live in Indiana. So I spoke to a gentleman last September. It was on a Friday afternoon. He lived in northern Indiana in Elkhart. He had lost his job, lost his insurance, had run out of insulin. He ran out of a short-acting insulin on Monday, hadn't taken any in 4 days, and he still had 2 days of Lantus left. He was on multiple daily injections. And I said, good gracious, stop talking to me and go to Walmart and buy some R. And he didn't have a clue what R was. And so one of the important factors of this is none of his healthcare providers, healthcare professionals, told him about R. You can't afford your drug, at least go get that and stay alive. He went to Walmart, and Walmart said, well, I'm sorry, you live in Indiana, we can't sell it to you without a prescription. So now you got to go pay your doctor a fee, go get to see him again and go get the prescription, or you can drive over the straight border to Michigan, which he was only 20 minutes away, and he did that and stayed and got his insulin. But I'm pleased to say that the governor of Indiana signed the bill on March 11th, and it goes into effect next year, which I'm a little unhappy about. It should have gone into effect this summer, but at least by next year, we will have this as a fail-safe option. A lot of other copay caps have been passed in states, Colorado and Illinois. It's pending in around 20 other states. It was introduced in Indiana, but did not get passed. As was rebate pass-through was introduced in Indiana and did not get passed. We were shot down by the insurance lobby, and they were very much against copay caps, and they were very much against rebate pass-throughs. And we didn't win, and we're not going to stop, but we didn't win. There's a lot going on at the state level. Please pay attention to the state level because we can do a lot of good for people with diabetes there.
All right.
So what's the fuss?
So what's all the fuss about? We talked about this once before in a slide. George, let's go to the next one. Diabetes care at schools. If you're in the United States, I know we've got a few people that aren't on this call, but if you're in the United States, in Indiana, it was called Hunter's Law for Hunter Seago, who many of you, if you're in Indiana, it's hard not to know the Seagos. They have been big advocates of school-based and other diabetes issues. Hunter recently graduated from Purdue, did he not, George?
DePaul.
DePaul. All right. Well, he played football. I wasn't sure which of those Yankee schools he played at.
And Jeff, if you could launch the poll, there's a poll on this one as well. Keep going.
All right. So, how kids are taught at school, the ADA leads the effort on that, but all of us that have diabetes should be involved in this because it's important whether you have a kid in school or not. The fact is that our kids spend more time in schools, except right now, our kids spend more time in schools sometimes than they are at home. So how they're treated at school and how they are able to self-manage and be safe is why the safe at school is important. Are we done, Jeff?
As that poll comes up, yeah, 26% have had an issue. So about 1 in 4 have had an issue, and about just under half didn't have a child in that situation.
Right.
I will say one quick story on this, if I may.
We got 10 minutes, George.
All right. Well, I'll be very quick then. Advocacy works, guys. Being a fuss maker works. And in this scenario, Kathy Sago and Hunter came up to Indiana, came up from southern Indiana to the state capitol in 10 inches of snow in a massive snowstorm on a cold day in February, showed up at a health committee hearing, and the opposition, who were in fact the school nurses, ironically, because they saw it as a job issue, they didn't show up because of the snow. We got through committee and they couldn't stop us. Showing up is so important in life, and it's very important in advocacy. I'll move us on. I think another poll on this one, but go ahead and talk, Stewart.
Non-medical switching. If there's a poll, just start it while I'm talking. Non-medical switching. How many people have had their insulin switched? Once again, this is a formulary issue. Have you had your insulin switched, your pump switched, your meter switched? How many people have had that happen? It is absolutely idiotic, and I will use that term because that's the strongest term I can use in public. Idiotic to take a stable patient and switch them for an economic reason only. If a doctor says they need to try something different, that's one thing. But the people that should be in charge of our medical treatment are the doctor's team, is the medical team. It's the CDE, it's the nurse, it's the dietitian, it's the doctor. It's not an insurance company or some medical person who may not have any diabetes experience at all. The big thing on this slide is that, 66% have had their insulin switched. The big thing on this slide, an endocrinologist who's already facing problems in paying bills because of the squeeze in their healthcare plans. Did you know they spend 1,500 unreimbursed hours a year on appeals? Because sometimes those appeals don't last for a full year. George, pumps?
Pumps. I'm going to keep us going here. So there's another poll on pumps, and this is about United Healthcare. So while you're answering the question, I'll talk about, the United Healthcare a little over a year ago came out with a deal with MiniMed, and it was a MiniMed pump or nothing if you were on the United Healthcare plan. Now, MiniMed makes a fine pump, so this is not a diss on their pump. It's a fine pump, but I'm a believer in choice. One of the things that advocacy works, fuss making works. Through advocacy, United Healthcare now accepts Omnipods, which is fantastic. I think they should accept more than that, but it's great. Fuss making works. What's next? One CGM, one blood glucose meter. What does the patient do to what is this? If they're limiting the choice, what happens to our health? What happens to our quality of life? What does that do to competition in the world and new development? Who in the world's going to come out with a new pump, a new CGM, if they can't access the market? So now there's nothing good that's going to come from that on behalf of people with diabetes. What happens if pumps are recalled and that's the only pump that you can have? And what happens? Other insurance companies follow United Healthcare's example. We need to continue to talk about that.
Hey, just a point of order. We're going to run a little bit over, so stick with us. George and Stewart have some additional and very important information to cover.
Yeah, and I don't think there's another person going to take our room because my kitchen's free. But if you, we do appreciate your time, and hopefully you're enjoying the conversation. And please do ask a question and send us something through chat if you've got something. I'm going to talk quickly about step therapy. If you know what step therapy is, it's a fail fast on their plan's preferred product. So if you're on fail fast scenario, medical guidelines do not recommend this one size fits all approach. And the real thing to me is you change your company or your insurance plan changes carriers. So you go from Cigna to Aetna to Blue Cross, and you start all over in your step therapy and you're failing fast. And since again, when is their accountant my doctor? Just these are things that are not in the patient's best interest. Copay accumulator adjustments. Now there's a poll here. How many of you guys understand how copay accumulator adjustments, how copay accumulators work?
I'm raising my hand.
You're raising your hand. That's good. If anybody were on there, it'd be great if we could just make you the presenter, because I don't have a clue, and I do actually. But these things are really, really hard to understand. But in very simple terms, these are the cards that the discount cards that you can get from the manufacturer. You have a drug that costs $400, $500. You get a drug that costs $500. You get a copay card that says it's only $100.
Or 75.
Or 75.
And the problem with these are that it doesn't go towards your deductible or your copay. So I don't understand why insurance companies don't allow it to go. If I want to pay George your deductible or your copay, why should your insurance company care? That's what the deal is about these cards. If your insurance company, why should your insurance company care who writes the check for the copay cards?
They shouldn't. They shouldn't, but they're using it to, again, save money, make money in the process. And if you're going to be able to use that card all year long, you're probably not impacted by any real pain, because you're paying $75 all year long. But if that copay card stops after 5 or 6 months, then suddenly you're going from $75 back to $500, and you haven't met your deductible. So all you've done is pushed your point of pain out. And it's not in the patient's best interest. And this is happening to products that don't have a generic alternative. If it had a generic alternative, which is the whole point of these, they're saying, oh, we don't want to have to pay for a brand drug when there's a generic alternative. Most of this stuff is happening when there is no generic alternative. So again, these are things to make a fuss about.
Pre-existing conditions. We all know what this is. Before the Affordable Health Care Act, we couldn't get insurance. If you had diabetes, you had a pre-existing condition. If you got it, it didn't cover it, or you couldn't get it at all. You had to go to a pool, and pool bills don't work. Pools don't work. So this is the patient protection that we need as people with chronic disease to manage our disease, okay? So those questions at the bottom of this slide are important.
And the thing to point out here, guys, is that there is a challenge to the Affordable Care Act in a Texas court right now. 18 states, including Indiana, are challenging the Affordable Care Act as we sit and speak today. If that court were to rule and make Affordable Care Act struck down, pre-existing conditions would no longer be protected. If that's done, and there's not a substitute for it, people with diabetes could suddenly be discriminated against legally. And hopefully we've raised enough awareness that wouldn't happen. But people tend to do what their wallet says they can do, and the insurance companies have a really big wallet and they do math really well. So beware, and if that comes up, it's time to be a fuss maker. Diabetes research. This is another area where federal funding for diabetes research does not keep pace with this disease and the cost of this disease. We are not getting our fair share. Please, please, please step in and help us raise awareness to your congressman to make sure that we continue to get pressure to increase the funding of research for diabetes. Medicare test strips. Stewart talked a little bit before about this. Medicare, how does that impact children with diabetes? Well, it impacts it because it tends to be the front runner. When Medicare does something, a lot of the insurance companies follow. So in order to get a CGM, they'll pay for, you need to have 4 tests a day in order to get a CGM, but they're only going to pay for 3 in the government's infinite wisdom. Type 2s only get 1. So it's often trend center. It's an area that we pay attention to because it can get us in trouble.
So how to make a fuss. It's easier than you think. Now, George is one of the best fuss makers I know. So how can I make a fuss? Next, get the alerts, personalize emails, send the emails, tell the senders your story. And the most important thing on this slide, repeat 1 through 5 as often as you can. You don't have to drive, and in today's world, you don't have to drive to your state house. You can send an email, you can send a letter. All these things work. You also don't have to drive to DC. You can send a letter, you can send an email. All these things work. Tools for advocacy. Hey, sign up as an advocate with ADA, JDRF, DPAC. Indy VLC is an information site, and come to us if you have a question. But DPAC, ADA, JDRF do federal and, well, JDRF doesn't do a lot of state issues, but ADA and DPAC do state issues. And JDRF does a lot of federal issues on diabetes research and other issues. So get involved, look it up. They're easy to get online and do, or make a phone call. It's an easy thing to do.
There's another poll. Are you currently registered as an advocate on one or more of these sites? Because it's really important, and I'm curious as to how many followers, believers we've got in this. Are we already fuss makers? Let's see how we're doing here. About half. That's very interesting. So the folks that said no, these websites are up there. ADA.org, JDRF.org, NDVLC.org, diabetespac.org. Please, please, please go there, sign up to be an advocate. This is not spam. If there's anything you do, go do that now. Are you ready to be a fuss maker? You don't have to be handy to use these tools. Are you ready to make a fuss? If I had a hammer, I'd hammer in the morning, I'd hammer in the evening, I'd hammer all over this land. We have an opportunity, guys, to make a difference on behalf of people with diabetes. Everyone on this call can make a difference on behalf of people with diabetes. 5 emails, 5 phone calls is a groundswell to a congressman, to a representative, especially at the state level. It is amazing how your voice can be heard. Awesome. There's only 2% that said, no, I do hope you just clicked wrong. I do hope you just clicked wrong. That's a little scary. So are you ready to make a fuss? And I do want to say this, a message from my friend Stewart Perry, who is a state
in the days of social distancing, we talk about we talk about what can you do and what can't you do. Jeff Hitchcock is called upon to stand up for people with diabetes because of his wide, varied knowledge of being a parent of a child with type 1 for how many years, Jeff?
It's over 31. 32
over 31. And nobody can ever accuse Jeff of being an uninvolved parent or uninvolved on both a national, state, and as a parent with his child. You don't all have to be Jeff Hitchcock. But what we need more people to say, wait a minute, and I'm going to show my age. I'm mad as heck, and I'm not going to take it anymore. Throw the TV out the window. Get excited. Go and do something. If it's just making one phone call or writing one letter, if it's just standing up against a system that you feel like is not doing right, tell the story, tell it loudly, tell it often. There's strength in numbers, not just 6 feet apart right now.
Very good. Well, I want to thank Stewart and George for a wonderful hour presentation. helping us understand the complexity of how we've gotten to where we are in terms of insulin pricing and access and all those other issues they talked about. For everyone who was on, when I end this in just a minute, there'll be a very brief 3-question survey. We'd really appreciate your feedback. And if you have any questions, want to learn more about what we do, you can reach out to us online, childrenwithdiabetes.com, or email info@childrenwithdiabetes. And finally, I'd like to thank again our sponsors, Lilly Diabetes, Dexcom, Insulet, Tandem Diabetes Care, and the American Diabetes Association. These organizations have helped make this possible. And with that, we're going to conclude our first virtual conference session on Friends for Life Indianapolis. We have 3 more later today, and we hope you can join us. Thank you all, and talk to you later.
Thanks, Jeff.
Thank you.